Hello, I am Dr. Jayakumar. Good evening, dear friends. Let me thank first of all Dr. Matthew John and the team for inviting me for this CME program. I have been asked to discuss about the role of radioiodine ablation in the management of differentiated thyroid cancer. As you know, the topic today, given we were very specific, radioiodine therapy after DTC, who needs it and who does not need it. It's very easy, you can answer in 2 minutes, but I have got 20 minutes to go. So I'll just introduce the topic, tell something about the management guidelines, and place of radioiodine ablation it, and further follow-up of DTC and take a more. Now, differentiated thyroid cancer is the most common endocrine malignancy. Most cases are comprised of differentiated subtypes, specifically papillary and follicular thyroid cancer. Surgical resection by way of thyroidectomy is the mainstay of treatment for this disease. However, adjuvant therapy in the form of radioactive iodine is often administered as a means of reducing the risk of tumor recurrence and to facilitate future cancer surveillance. So the aim of follow-up is early identification of a small proportion of cases, less than 20% of cases, who have residual tumor or who are going to develop the recurrence. How long will you follow these patients? Maximum recurrence is within the first 2 to 3 years, but distant metastasis has developed even after 20 years of initial treatment. So I personally feel the follow-up must be lifelong. What are the goals of therapy of cancer? Facilitate post-operative treatment with radioactive iodine where appropriate, to permit accurate long-term surveillance for the disease recurrence, and to minimize the risk of disease recurrence and metastatic spread. And what is the role of post-operative staging and it should be used? Because of its utility in predicting the disease mortality, and its requirement for cancer registries, AJCC and the UICC staging is recommended for all patients with differentiated thyroid cancer. The use of postoperative clinical pathological staging system is also recommended to improve the prognostications and to follow for patients with differentiated thyroid cancer. This slide is very difficult to follow or to see, but this is just a slide I taken copied from American Thyroid Association 2015 guidelines for indications for staging the differentiated thyroid cancer. So those who are interested can go to the website of American Thyroid Association and get a detailed this on. And it is staged taking into consideration the size of the tumor, the presence of metastasis, extrathyroidal spread, and all those things. And on that basis is being classified. And so the today's topic is about radioiodine ablation. So what is this radioiodine which is used for ablation? It is radioiodine 131. Physical half-life is 8.02 days. It mainly emits beta rays. 90% of the radioactivity of ion 13 is beta rays, and the rest is gamma rays. Most of the radiation dose is delivered by beta particles. Beta particles do not penetrate deep into the tissues. The maximum depth it can damage is only 2 millimeters in depth. And ion 31 is available for oral injection as sodium iodide as a liquid form or in capsules. The rationale of ion 31 is to destroy any residual microscopic disease, to increase the specificity of subsequent ion 31 screening for the detection of recurrent or metastatic disease by the elimination of uptake by residual normal tissue, to improve the value of measurements of serum thyroglobulin as a serum marker for derived from only the malignant thyroid cells. So if you destroy all the cells in the body, whatever thyroglobulin is coming must be from the new tissue. The use of large amount of ion 31 for therapy permits post-operative iodine 131 total body scanning, a sensitive test for detecting persistence of carcinoma or metastasis. What are the benefits of therapy? It decreases local recurrence, improves survival in patients following local recurrence, and improves patients' conditions with more metastasis. Indications are Based on the risk stratification of the individual, the primary goal of the first dose of total thyroidectomy may be reminal ablation to facilitate detection of recurrent disease and initial staging, adjuvant therapy to decrease recurrence of recurrence and disease-specific mortality by destroying suspected but unproven metastatic disease, and radioagent therapy to treat known persistent disease. And radioablation, radioactive iodine ablation is recommended for all patients with known distant metastasis. Gross extrathyroidal extension of the tumor regardless of the tumor size. And primary tumor size of more than 4 centimeters, even in the absence of other high risk factors. And radioiodine ablation is recommended for select patients. Our relative indication is between 1 to 4 centimeter thyroid cancers confined to the thyroid, documented lymph node metastasis, other higher risk of features when the combination of age, tumor size, lymph node status, and individual histology predicts an intermediate to high risk of recurrence or death from thyroid cancer. Radioiodine ablation is not recommended for patients with unifocal cancer less than 1 centimeter without other higher risk features. Radioiodine ablation is not recommended for patients with multifocal cancer when all the foci are less than 1 centimeter in the absence of other high risk factors. How should the patient be prepared? Patients undergoing radioiodine therapy or diagnostic testing can be prepared by thyroxine withdrawal for at least 2 to 3 weeks, or give LT3, thyroid therapy for 2 to 3 weeks, and LT3 withdrawal for 2 weeks, and measurement of serum TSS system in the timing of testing. And the TSS must be at least more than 30 milli-international units before you give radioiodine ablation. And the thyroxine therapy with or without LT3 for 7 days may be resumed on the second or third day after the radioiodine administration. Can recombinant human TSS be used instead of thyroxine withdrawal? Yes. Reminal ablation can be performed following thyroid withdrawal for 2 to 3 days, or reminal ablation can be performed following thyroid withdrawal or after giving recombinant TSS stimulation. Should RA scanning be performed before ablation? Pre-therapy scans and their measurement of thyroid beta uptake may be useful when the extent of thyroid remnant cannot be accurately ascertained from the surgical report or net ultrasonography, or when the results would either will alter either the decision to treat or the activity of the dose of the radioiodine to be administered. If performed, pre-therapy scan should utilize I-123. We have 1.5 to 3 millicurie or low activity I-131 1 to 3 millicurie with a therapeutic activity optimally administered within 72 hours of the diagnostic activity. Minimum activity is 30 to 100 milli-international units necessary to achieve successful reminal ablation. It should be used particularly for low-risk patients. If residual microscopic disease is suspected or documented, or if there is a more aggressive tumor histology like tall cell, insular, columnar cell carcinoma, then higher doses of 100 to 200 millicurie may be appropriate. A low dose, a low diet for 2 weeks is recommended for patients undergoing radioiodine reminal ablation, particularly for those patients with a high iodine in there. Should a post-therapy scan be performed following reminal ablation? A post-therapy scan is recommended following radioiodine reminal ablation. This is typically done 2 to 5 days after the therapeutic dose is administered. Published data supporting this time interval are lacking. What are the criteria for the absence or your treatment was successful? No clinical evidence of tumor, no imaging evidence of tumor, no uptake outside the thyroid bed and the initial post-treatment whole body scan, or if uptake outside the thyroid bed had been present, no imaging evidence of the tumor on a recent diagnosis scan or ultrasound neck, undetectable serum thyroglobulin level during TSS suppression, and stimulation suppression or stimulated in the absence of interfering antibodies. What are the post-surgery and radioiodine therapy management BTC? The follow-up protocol after radioiodine ablation includes thyroglobulin measurement and anti-thyroglobulin antibody measurement, whole body radioiodine scan, neck ultrasound, and TSH suppression therapy. Serum thyroglobulin assays in the follow-up. Measure the thyroglobulin levels is important modality to monitor the patients for the residual or recurrent disease. In the absence of antibody interference, serum thyroglobulin has a high degree of sensitivity and specificity to detect thyroid cancer, especially after total thyroidectomy and remnant ablation. With the highest degrees of sensitivity noted following thyroid hormone withdrawal or stimulation using human recombinant TSS. A single human recombinant TSS stimulates serum thyroglobulin of less than 0.5 nanogram per ml in the absence of anti-thyroglobulin antibody as an approximately 99.5% likelihood of identifying patients completely free of tumor on follow-up. A rising unstimulated or stimulated serum thyroglobulin indicates disease that is likely to become clinically apparent. After the first, the whole body diagnostic RRA scan, after the first whole body post-treatment scan performed 6 months after the radioactive permanent ablation, low-risk patient with an undetectable thyroglobulin on thyroid hormone with negative anti-thyroglobulin antibodies and a negative ultrasound do not require routine whole body scan after that. So 6 months after the first post-therapy whole body scan, if it is completely normal, and further scans are not indicated unless there is changes in the thyroglobulin and ultrasound itself. Ultrasonography. Following surgery, ultrasound to evaluate the thyroid bed and central and lateral cervical nodal compartment should be performed at 6 to 12 months interval and then periodically, depending upon the patient's risk for recurrent disease and thyroglobulin status. If a positive result would change management, ultrasonography suspicious lymph nodes greater than 5 to 8 millimeter in the smallest diameter should be biopsied for cytology with thyroglobulin measurement in the needle or fluid. Suspicious lymph node less than 5.8 in the largest diameter without biopsy with consideration for intervention if there is a growth or if the node threatens vital structures. For follow-up of differential carcinoma thyroid, thyroxine therapy, the serum TSS should be maintained below 0.1 MI unit in the first few years in the absence of specific contraindications. In patients who are clinically and biochemically free of disease and who presented with high-risk disease, consider to maintain T4 suppressive therapy to achieve serum TSS levels around 0.01 to 0.5 MIU for 5 to 10 years. And in patients free of disease, especially low risk of recurrence, serum TSS may be kept within the low normal range of 0.3 to 2 MIU. In patients who have not undergone remnant ablation and who are clinically free of disease and have undetectable or suppressed serum thyroglobulin and normal neck ultrasound, the serum TSS may be allowed to rise to a low normal level of 0.3 to 2 MIU. So the conclusions, after near total thyroidectomy, patient is sent for remnant I-130 ablation if indicated, suppressive therapy with thyroxine, whole body scan at 6 months, serum thyroglobulin ultrasound neck after 6 months, continuous suppressive therapy with thyroxine and yearly thyroglobulin neck ultrasound, and continuous therapy and screening lifelong. So the absolute indication for radioiodine therapy is one inoperable tumor, post-operative gross residual disease, known nodal or distant metastasis, gross extrathyroidal extension of the tumor regardless of the tumor size, or primary tumor size more than 4 cm even in the absence of other high-risk factors, and post-operative unstimulated thyroglobulin more than 5 to 10 Relative indication for I-130 therapy is 1 to 4 centimeter thyroid cancers confined to thyroid have documented lymph node metastasis. Other high-risk features like combination of age, tumor size, lymph node status, and individual histology predicts an intermediate to high risk of recurrence of death. Histological subtypes like tall cell, columnar cell, insular cell, and solid variants, as well as poorly differentiated thyroid cancer, and the presence of intrathyroid vascular invasion, the finding of gross or microscopic multifocal disease. And radioiodine therapy is not indicated in radioiodine ablation is not recommended for patients with unifocal cancer less than 1 centimeter without other high risk factors, and it's not recommended if a patient with multiple organ cancer when all the foci are in the absence of other high risk factors. Thank you very much for the patient here. Thank you once again. I am willing to clarify some of your doubts. Thank you.